Welcome to the deep dive. This is where we take those really dense, rigorous sources, the ones you're probably up late studying right now, and we try to boil them down into these memorable, high-yield frameworks.
That's exactly right. And today our mission is, well, it's pretty laser focused. We're talking directly to you, the first or second year medical learner, and we're going through the cardiovascular essentials, all distilled from Davidson's medicine.
And the job isn't just to summarize, is it?
No, not at all. It's about synthesis. We want to link the core physiology, the mechanisms, and the pathology into these foundational blocks. You know, the anchors you absolutely need to build on for the rest of your career.
We really have to start with just the sheer magnitude of this topic. I mean, why do we spend so much time here?
Well, because cardiovascular disease remains the grim, enduring global champion of what kills us.
Right. It causes more deaths than anything else. The sources, they remind us we're talking about something like 3.8 million men and 3.4 million women dying from coronary heart disease.
Every single year. The statistics are just staggering. But there's this really vital clinical paradox here.
Which is what?
On one hand, we have this exceptionally strong evidence base for treating these diseases. The therapies are fantastic. But on the other, prompt recognition is, well, it's often very limited.
Why is that? Why do we miss it?
Because the pathology is clinically silent for so long, the damage is just quietly accumulating beneath the surface for decades. And that's why you, as the future clinician, need to learn how to spot those really subtle red flags early on.
Absolutely. That silence is so deceptive. So our framework for this deep dive is to kind of build the heart from the ground up.
Exactly. We'll start small with the cardiac cell and its electrical grid.
Then scale up to the macro circulation, the plumbing, so to speak, and then finally dive into the major disease categories like heart failure, atherosclerosis, and arrhythmias.
You really can't fix the engine until you understand the blueprint and the wiring.
So let's start with that blueprint. Let's zoom right into the cell. Our first core concept has to be myocardial contraction.
Right. We're talking about the myocyte, this specialized muscle cell. It's tiny, maybe 50 to 100 micrometers long, and it branches and connects with its neighbors through these really critical structures called intercalated discs.
And the intercalated disc is more than just a connection, right?
Oh, absolutely. It's fascinating. It serves as both the electrical and the mechanical link. You have gap junctions, which are like little tunnels that allow for lightning-fast electrical conduction between the cells.
So the whole tissue depolarizes almost instantly.
Exactly. And then you have the fascia adherens, which are the mechanical attachments. They're like the rivets, ensuring that when one cell contracts, it pulls its neighbor along with it, perfectly in sync.
Without them, the muscle would just tear itself apart.
Or beat completely inefficiently. But the real engine inside the cell, the functional unit, is the sarcomere. It's only about 2 micrometers long.
And that's made up of the two main protein filaments. Actin, the thin ones, and myosin, the thick ones.
And that's our first big anchor metaphor. Think of the sarcomere as a sliding door mechanism. The actin and myosin filaments have to slide past each other to shorten the whole unit. That is contraction.
But critically, when the heart's relaxed, that sliding door is locked shut.
It is, which immediately brings up the question.
What's the key that unlocks the door?
The key is calcium. This mechanism is really what makes cardiac muscle unique. Contraction starts when calcium ions first enter the cell from the outside during the plateau phase of the action potential. That's the initial trigger.
A small amount of calcium comes in.
A tiny amount. And that small influx then triggers this massive release of even more calcium from the cell's internal storage unit, the sarcoplasmic reticulum. We call it calcium-induced calcium release.
It's a tiny spark setting off a huge explosion of calcium.
So once you have that flood of calcium, how does it actually interact with the door lock?
The calcium binds to a complex called troponin, specifically a troponin complex that's attached to every seventh actin molecule.
Now, ordinarily, another protein, tropomyosin, is just physically blocking the binding site on actin where the myosin head wants to attach.
It's in the way.
It's in the way. But when calcium binds to troponin, it's like turning the key. It physically moves tropomyosin out of the way and unlocks that binding site.
And once it's unlocked, the myosin head, which has the enzyme myosin ATPase for energy, it just snaps into place, pivots, and then pulls the actin filament.
Exactly. It uses energy from ATP to tilt and pull, shortening the sarcomere and generating force. It's a beautifully choreographed, very energy-intensive process.
And this brings us to a huge clinical point. The force of contraction, what we call the inotropic state, is directly regulated by that initial calcium influx through those slow calcium channels.
Right. The more calcium that comes in, the bigger the triggered release from storage, and the stronger the heart squeezes.
I see why the sources make a quick but really important distinction about heart failure here. They say the enlargement you see in a failing heart is due to myofibral slippage, not the sarcomeres themselves, just overstretching. Why is that distinction so critical for a learner to grasp?
Because it tells us that heart failure is fundamentally a structural disease. It's not just like a stretched out rubber band.
Right.
If it were just over-lengthening, you could maybe fix it by just optimizing the preload. But the fact that we see myocyte loss and slippage, it means the underlying architecture of the heart is failing. It tells you that chronic neurohumoral activation is causing irreversible structural damage, which is a major theme we will definitely come back to.
That's a perfect synthesis. So the key takeaway here is that cardiac contraction is a caltroponin tropomyosin-driven mechanism, and it's powered by myosin ATPase.
Exactly.
All right, let's do a quick check-in then. Based on that mechanism we just laid out, if a clinician gives a patient a drug that blocks those slow calcium channels, what specific cardiac function are they trying to reduce or control?
And, why would they want to do that? Take a moment to think about what happens if you reduce that initial calcium spark. If you're not sure, just rewind and listen to that calcium trigger section one more time.
The function you're reducing is the force of contraction, the inotropic state. Clinically, you'd use a calcium channel blocker like verapamil or diltiazem to, say, manage angina by reducing the heart's oxygen demand, or maybe to control the rate in certain arrhythmias.
Exactly.
So now we know how the cell contracts. Let's trace the signal that tells it to contract the heart's electrical grid.
Right, the cardiac conduction system. This is all about perfect timing. It starts in the sinoatrial node, the SA node. That's the heart's natural pacemaker.
And that initiates the wave of depolarization.
Which spreads through the atria, and you see that on the ECG as the P wave.
And then the signal hits the atrioventricular, or AV node. And this is where the whole process it pauses for a moment. There's a deliberate delay.
And that delay is absolutely essential for life. It provides the necessary time, that mechanical window, for the ventricles to fully fill with blood after the atria contract, the atrial kick, before they get the signal to squeeze.
If that delay isn't there, ventricular filling would just plummet.
It would be a disaster. So from the AV node, the signal then blasts down these high-speed wires, the His-Purkinje system.
The bundle of His, the right and left bundle branches, and then the final Purkinje fibers.
And the key word here is rapid. This rapid conduction ensures that the huge mass of the ventricles depolarizes almost simultaneously. It's all about maximizing pump efficiency.
And this whole path is perfectly mapped onto the ECG waveforms we see. You said the P wave is atrial depolarization.
Right. And the PR interval, that measures the duration of that AV nodal conduction.
Yeah.
So if the PR interval is prolonged, we know there's a delay or an injury right there in the AV node.
When that electrical signal hits the big ventricular muscles, we get that sharp, narrow QRS complex. That's ventricular depolarization.
Mm-hmm. And if there's damage in those high-speed bundle branches, the signal takes longer to spread out, and that leads to a widened QRS complex, a really significant diagnostic clue.
And finally, we get the T wave, which is ventricular repolarization, and the QT interval, the total time for the ventricles to depolarize and then repolarize.
And a little nuance the sources point out is that ventricular repolarization actually spreads from the outside in from the epicardium to the endocardium.
Okay, let's move from the electrical grid to the fluid highway.
Yeah.
Let's talk circulation and vascular dynamics. Once the left ventricle squeezes, the blood hits the aorta. And this is where we have to introduce our first really critical mechanical concept.
The Windkessel effect. The aorta and the big central arteries, they aren't just stiff pipes. They are made mostly of elastic tissue, which makes them really compliant. And that compliance is a huge functional advantage.
So when the heart ejects blood during systole, the aorta actually expands to accommodate that surge of volume.
Exactly. But then what happens during diastole when the heart is relaxed and not ejecting blood?
The aorta's stored elastic energy recoils.
It recoils. And that sustained recoil maintains blood pressure and keeps the blood flowing forward. This Windkessel effect is essential. It prevents your systolic pressure from spiking too high, and crucially, it maintains your diastolic blood pressure.
And why is maintaining that diastolic pressure so critical for the aorta's job?
Because that is when the heart feeds itself. Coronary artery perfusion happens almost exclusively during diastole when the aortic valve is closed. If that diastolic pressure drops too low, the heart muscle itself begins to starve.
And that's the first thing you lose when arteries stiffen with age or disease, isn't it?
It is, which is why hypertension is so devastating long term.
Okay, so the blood then flows to the resistance vessels. And the sources emphasize that the biggest contribution to systemic vascular resistance, or SVR, comes from these tiny arterioles.
Only 50 to 200 micrometers in diameter. And this brings us to a fundamental physics principle you absolutely have to internalize, Poiseuille's law.
And this law is, well, it's terrifyingly powerful in biology.
It is. It tells us that resistance is inversely proportional to the fourth power of the radius. So R is proportional to 1 over R to the fourth.
Okay, so let's make that real. If I have a vessel and its radius shrinks by just half because of, say, sympathetic constriction, what happens to the resistance? It doesn't double.
It doesn't double, it doesn't quadruple. It increases 16-fold.
Wow.
That's the power of the fourth power. It means that the body only needs to make tiny adjustments in the tone of those arterioles to have a massive immediate impact on blood flow and pressure. It's an incredible control mechanism.
One that can be easily hijacked by disease.
Exactly. And that tone is tightly regulated. Neurogenic constriction uses alpha adrenoceptors, and dilatation uses things like muscarinic and beta-2 adrenoceptors.
We can't really talk about vascular dynamics without mentioning the endothelium, can we? That single layer of cells lining every blood vessel.
No, it's far from being just a passive surface. The endothelium is incredibly active. It regulates inflammation, it recruits inflammatory cells, and it maintains this crucial, delicate balance between forming clots and dissolving them.
The sources are really clear on this dual role. On one hand, it promotes clotting by releasing von Willebrand factor, which helps platelets stick to damaged surfaces.
Right. But on the other hand, it's the body's rapid response clot buster. It can instantly release tissue plasminogen activator, or TPA, to kick off fibrinolysis.
So when the endothelium gets damaged, say from hypertension or chronic inflammation, that balance is just completely disrupted.
It is. The whole system shifts towards inflammation, vascular dysfunction, and that's the starting point for almost all coronary artery disease.
Okay, finally in this section, let's touch on the intimate connection between the heart and the lungs, the cardiorespiratory interactions. This can be a source of confusion, but it all hinges on pressure changes in the chest during breathing.
Exactly. When you take a deep breath in inspiration, the pressure inside your chest drops. That fall in pressure dramatically increases venous return to the right side of the heart, which boosts the right ventricle's output.
But at the same time, that negative pressure also causes blood to be temporarily held or sequestered in the lungs because the pulmonary vascular capacitance increases.
Right. And that sequestration means less blood is flowing from the lungs into the left atrium and left ventricle. So for a moment, the left ventricle's output drops and you get a slight momentary fall in your systemic blood pressure.
And expiration just reverses that whole sequence.
Completely. Venous return to the right heart falls, but blood moves from the lungs to the left heart, LV output goes up, and systemic BP rises slightly. Normally, it's just a few milli-HG difference.
But this normal fluctuation can become really exaggerated in a critical clinical sign called pulsus paradoxus,
which is defined as a systolic BP fall of more than 10 millimilli-HG during inspiration. And pulsus paradoxus is a massive red flag.
You see it in two main scenarios, right?
Right. First, in severe airways obstruction, like asthma or COPD, where the pressure swings are just extreme. But most critically, it's a characteristic sign of cardiac tamponade.
In tamponade, the heart is being squeezed by fluid on the outside. So when the patient breathes in, that increased venous return to the right heart has nowhere to go.
So it forces the interventricular septum to physically bow leftward into the constrained left ventricle,
which acutely impedes the LV from filling.
And its output plummets. The resulting drop in systemic blood pressure is really pronounced. That septal shift is the anchor you need to remember to explain this sign.
Okay, time for a critical thinking check-in. A patient is in the emergency department with acute respiratory distress. The team measures their systolic BP at a 115 during exhalation, but it falls to 98 when they take a deep breath. Which two major conditions must be at the top of your differential diagnosis?
Think about the size of that drop. It's 17 millimilli-HG. The two conditions that cause this extreme pulsus paradoxus are severe airways obstruction, or, much more worryingly, cardiac tamponade. If you didn't immediately picture that interventricular septum shifting, just rewind and revisit that tamponade mechanism.
All right, let's move from the healthy blueprint to a major pathology. Heart failure. This is a huge topic affecting millions, and it's really a disease of aging population.
It is, and we have to emphasize the prognosis. Untreated severe heart failure has an appalling outlook. The source says it's around 50% mortality within 2 years. People die from either terminal pump failure or from sudden malignant arrhythmias.
The core issue is reduced cardiac output. And when that happens, the body's survival mechanisms just kick into overdrive. We get activation of the sympathetic nervous system, the renin-angiotensin-aldosterone system, or RAAS, and others.
In the short term, this actually works. It maintains perfusion and volume. But in the chronic state, the sustained neurohumoral activation becomes severely detrimental.
Which brings us to our conceptual centerpiece for heart failure, the vicious circle. That initial compensation, the SNS and RAAS activation, it drives two disastrous long-term problems.
Increased afterload from vasoconstriction and increased preload from salt and water retention.
And this creates a relentless positive feedback loop that just dramatically increases the workload on an already failing heart.
Right, and things like angiotensin II and aldosterone, they don't just constrict vessels, they actively promote myocardial fibrosis and pathological remodeling. It just accelerates the myocyte loss and makes things worse and worse, spiraling the patient down.
So breaking that vicious circle is the absolute foundation of our treatment strategy.
It is, and to understand the management, we have to revisit Starling's law. Normally, ventricular performance increases with preload, with stretch-up, to an optimal point.
But in heart failure, that whole Starling curve shifts down and to the right, and it becomes much flatter.
Meaning the heart responds really poorly to increased stretch. In fact, if you overstretch it, which is common in these volume-overloaded patients, their function gets markedly worse.
And that's why the treatment seems so counterintuitive, right? In a healthy person, a diuretic would reduce cardiac output.
Exactly. But in a failing volume-overloaded heart, reducing preload can actually dramatically drop the filling pressure with no change, or even an improvement in cardiac output. You're just bringing the heart back to a more efficient operating point on its failing curve.
Okay, let's pivot to how this actually presents clinically. Acute left heart failure is a catastrophic event.
It is a sudden onset of shortness of breath at rest, progressing rapidly to respiratory distress. You'll look for signs like a gallop rhythm, that S3 sound.
And you might even hear a new systolic murmur.
Right, which could indicate something disastrous, like acute mitral regurgitation from a ruptured papillary muscle after a heart attack. And on the chest, the hallmark is inspiratory crepitations or crackles over the lung bases. That's pulmonary edema.
Now, chronic heart failure is more of a relapsing and remitting course. And we can categorize the signs into low output or congestion.
Low output signs are things like fatigue, poor effort tolerance, cold peripheries, low blood pressure, and poor renal perfusion.
And the congestion signs.
Well, left heart failure gives you pulmonary congestion, so dyspnea and crepitations. Right heart failure gives you systemic congestion, so you'll see a highly elevated jugular venous pressure, or JVP, a tender congested liver, and dependent peripheral edema.
In the ankles and legs if they're walking, but in the sacrum and thighs if they're bedbound. You have to check.
You have to check. And the complications are serious. Renal failure is extremely common. Electrolyte problems like low potassium are a constant worry. And the most terrifying is sudden cardiac death. As many as half of heart failure deaths are sudden from ventricular fibrillation.
When we look for evidence, the imaging anchor is the chest x-ray. What are we looking for?
We look for signs of pulmonary congestion, like distension of the upper lobe veins. But the classic high-yield sign of interstitial edema is the appearance of septal lines, or curly B lines.
Those short horizontal lines you see at the lung peripheries.
Exactly. They represent thickened interlobular septa from fluid leaking out, a classic sign.
So how do we manage this in the acute crisis with pulmonary edema?
Patient has to be sitting upright, continuously monitored. 4B opiates can help with the distress. But the key intervention is IV nitrates, like GTN. They are powerful vasodilators that massively reduce preload, and they also reduce afterload.
And you titrate that aggressively.
You titrate until the patient improves, or until their systolic blood pressure drops below 110.
For chronic therapy, the goals shift entirely to breaking that vicious circle.
Right. And the big three drug classes are V blockers, ACE inhibitors, or ARBs, and mineralocorticoid receptor antagonists, or MRAs. They are the cornerstones because they directly interrupt that neurohumoral pathway.
And it seems counterintuitive to give a beta blocker to a failing heart.
It does, but they reduce oxygen demand, they prevent myocyte toxicity from all the adrenaline, and they reduce the risk of sudden arrhythmic death. They are proven to improve survival.
What about digoxin?
We use digoxin for rate control if the patient also has atrial fibrillation. The source is very precise here. Digoxin reduces hospitalization, but it has no effect on long-term survival. That distinction is key.
There's also a newer strategy targeting an enzyme called neprilysin.
Right. Neprilysin normally breaks down beneficial natriuretic peptides. So if you inhibit it, you preserve those good peptides while still blocking the RAS pathway. It's a superior way to counteract the vicious circle.
And for end-stage failure.
We sometimes turn to ventricular assist devices, or VADs, mechanical pumps. They're life-saving, but they come with huge risks. Hemorrhage, embolism, infection. They're not a simple fix.
Okay, let's pause for a reflection. You're reviewing the chest X-ray of a patient with acute on chronic heart failure. The radiologist notes the presence of curly B lines. What specific underlying physiological process does that finding represent?
Think about what those lines actually are. Thickened septa. The answer is interstitial pulmonary edema. It's a direct consequence of chronically and severely elevated left atrial pressure causing massive pulmonary congestion. If you didn't connect it back to the pressure, review that CXR anchor again.
All right, let's move to the leading global cause of death, coronary artery disease, which is driven by atherosclerosis. This is where we need to connect inflammation, biology, and acute pathology.
Right. And atherosclerosis isn't just a simple plumbing blockage. It's a progressive inflammatory disorder of the arterial wall. It's characterized by these focal lipid-rich deposits called atheroma.
And critically, it's silent for decades.
For decades, until it either causes severe obstruction or, much more dramatically, it ruptures. And the progression starts incredibly early in life. We see early lesions in young adults, often at specific spots like vessel bifurcations where there's altered shear stress.
But the clinical signs, the chest pain, the heart attacks, they might not show up until the 6th, 7th, or 8th decade.
It's a disease of decades, not days. And to master this, you need the AHA classification. That's our structural progression anchor. The initial stages, type I and II, are silent. Just some macrophage foam cells, the fatty streak. That starts in the first decade of life.
Then around the 3rd decade, it gets more serious. Type 4, the atheroma, is when a core of extracellular lipid forms.
Type V, the fibrotheroma, is where a fibrous layer covers that lipid core. That's what we call a stable plaque.
But the real danger is type 6, the complicated lesion.
Exactly. That involves a surface defect, a hemorrhage, or a thrombosis. This is the lesion that causes clinical events, and it highlights the critical difference between a stable plaque and a vulnerable plaque.
A stable plaque has a small lipid core and a thick protective fibrous cap. It might cause stable angina, but it's not likely to rupture.
The vulnerable plaque, though, that's the ticking time bomb. It has a large, hot, lipid-rich core, a thin, weak cap, and it's just crawling with inflammatory cells that are releasing enzymes that degrade that cap.
So rupture is often triggered by a sudden surge in blood pressure, like from exercise or stress.
Right, and when that thin cap breaches, the highly thrombogenic contents are exposed to the blood, and that initiates immediate platelet aggregation and the formation of a coronary clot.
And the sources highlight a few key points here. Age is the most powerful risk factor. And for women, the protection they have pre-menopause vanishes afterwards.
And the source makes a very strong point. Hormone replacement therapy is not recommended for CAD prevention. In fact, it might actually increase the risk.
So this atherosclerosis causes the clinical syndrome of angina, which is, at its heart, a supply-demand imbalance.
And the key mechanical point is that myocardial oxygen supply happens mainly during diastole.
Stable angina is that predictable exertional chest pain. It's caused by a fixed obstruction that only limits flow when demand goes up.
Right, and so management is about reducing demand with beta blockers and maximizing supply or reducing preload with things like GTN.
Acute coronary syndrome, or ACS, is the umbrella term for unstable angina and myocardial infarction, or MI. And that's always driven by plaque instability.
And we have to delineate the two primary types of MI. Type 1 MI is the classic one, an occlusive thrombus at the site of a plaque rupture, atherothrombosis. And the infarct progresses over hours, so it's a race against time to get that vessel open.
But type 2 MI is also really important.
It is. This is an MI caused purely by a supply-demand mismatch. Think about a patient in severe sepsis or with a really fast arrhythmia. If they have underlying CAD, even without a rupture, that extreme stress can starve the myocardium and cause ischemic necrosis.
Diagnosis relies on ECG changes, ST elevation or depression, and critically elevated cardiac troponin.
Troponins are highly specific biomarkers of myocardial damage, And they rise much faster than the older markers, which gives us the prompt, reliable diagnosis we need.
Treatment hinges on revascularization. In chronic stable angina, we have percutaneous coronary intervention, or PCI, the balloon and the stent.
And here's a really key concept to anchor your future decision-making. While PCI is great at controlling symptoms in chronic stable angina, the data shows it does not reduce the risk of future MI or improve survival compared to optimal medical therapy alone.
So in chronic stable disease, it's primarily a symptomatic tool.
Exactly. But coronary artery bypass grafting, or CABG, is different. That's major surgery. And the sources emphasize that CABG does improve survival, especially in patients with really severe disease, like left main stem or three-vessel disease, particularly if their LV function is already impaired.
The survival benefit dictates the choice.
It does.
Yeah.
And in the acute setting of a STEMI, reperfusion is an emergency. Primary PCI, if you can get it done within 120 minutes, is the treatment of choice. It dramatically improves mortality.
And after the acute phase, the focus shifts entirely to secondary prevention.
Which is non-negotiable. Dual antiplatelet therapy, statins, and 2 drug classes that are critical for long-term survival. Blockers, which reduce mortality by about 25%, and ACE inhibitors, or ARBs.
Why the intense focus on ACE inhibitors post-MI?
Because they're the drugs that counteract late ventricular remodeling. An infarct area doesn't just heal. The remaining viable muscle adapts pathologically. It thins, it dilates, becomes less efficient. ACE inhibitors prevent that structural deterioration and stop the transition into chronic heart failure.
Let's check that understanding. A patient is stabilized after a large anterior MI. Which therapy is most effective at preventing that detrimental late remodeling and subsequent heart failure? The IV nitrates used in the acute phase, or long-term prescription of an ACE inhibitor?
Pause and think about the difference between acute hemodynamic relief and long-term structural modification. If you need a refresher on the vicious circle, you can rewind to part 2.
The answer is long-term ACE inhibitor, or ARB therapy. While nitrates are essential acutely, only blocking the RAS pathway long-term has been shown to counteract that structural dilation and fibrosis that leads to chronic heart failure after an infarct.
Okay, let's move to the faulty wiring cardiac arrhythmias. The guiding principle here is pretty simple. Treat precipitating factors first.
So correct electrolytes, especially potassium, treat thyroid issues, address ischemia, limit triggers like alcohol.
And always try to use as few antiarrhythmic drugs as possible.
We'll start with the slow rhythms, the bradyarrhythmias. Sinus bradycardia can be normal, but if it's symptomatic, we can use IV atropine.
Right, a muscarinic receptor antagonist that speeds up the SA and AV nodes. If it's persistent and severe, though, the patient often needs a permanent pacemaker.
Then we have the AV blocks. First degree is usually benign, but second degree has 2 types with very different prognosis.
Mobitz first, or vancomycin, is that characteristic progressive lengthening of the PR interval until a beat is finally dropped. It's often in the AV node itself.
Mobitz 2 is much more serious.
It is. Here, the PR interval is constant, but every second P wave just fails to conduct. This often represents a block below the AV node, and it carries a high risk of sudden, complete asystole. It often requires immediate temporary pacing.
Moving to the fast chaotic rhythms, atrial fibrillation, or AF, is the most common sustained arrhythmia. Its prevalence just soars with age.
And it doubles mortality risk and is a major cause of stroke.
The mechanism anchor for AF.
It's triggered by ectopic beats, often from the pulmonary veins. These triggers then sustain the rhythm through multiple interacting reentry circuits in the atria. The atria are just beating chaotically.
Which gives you that classic ECG pattern of irregular QRS complexes and no discernible P waves. The pulse is irregularly irregular.
And management is split between rate control and rhythm control, but the most crucial management priority is stroke prevention.
Because the atria are just fibrillating, not contracting, blood stagnates, especially in the left atrial appendage.
And that stasis leads to thrombus formation and systemic embolism. So anticoagulation is mandatory, guided by the CHAO's risk score. And the source explicitly warns that aspirin alone is insufficient and still carries a bleeding risk. That is a critical lesson.
What about supraventricular tachycardia, or SVT?
That's usually a regular, narrow, complex tachycardia, and it almost always uses the AV node as part of its reentry circuit.
And the immediate diagnostic and therapeutic anchor for SVT is IV adenosine.
Right, a rapid IV bolus. Adenosine binds to A1 receptors and causes a profound but very transient AV block that lasts just a few seconds.
And that's often enough to just interrupt the circuit and terminate the arrhythmia.
Or it's diagnostic. If the rhythm doesn't stop, but you briefly see the underlying atrial rhythm, like the sawtooth pattern of atrial flutter, then adenosine has done its job.
The more serious arrhythmias are the ventricular ones. Ventricular tachycardia, or VT, is often caused by reentry circuits around scarred tissue post-MI.
And to diagnose VT, you have to spot those pathognomonic ECG signs. Look for atrioventricular dissociation P waves and QRS complexes marching to completely different drums.
And also capture beats or fusion beats.
Exactly. Those tell you the ventricle is in charge. Sustained VT is an emergency. If the patient is hypotensive, it's immediate synchronized DC cardioversion. If they're stable, you can try IV antiarrhythmics like amiodarone.
And on the long-term side, technology has been a game changer.
It has. Catheter ablation, using heat or freezing to destroy the culprit electrical tissue, can offer a lifetime cure for many arrhythmias like AV-NRT.
And for preventing sudden death, we have implantable cardioverter defibrillators, or ICDs.
Which are crucial for high-risk patients, those with poor LV function post-MI or certain cardiomyopathies, to deliver a life-saving shock if they go into ventricular fibrillation.
All right, quick reflection. A young patient has a rapid, regular, narrow complex tachycardia. You give IV adenosine, and the rhythm immediately breaks. What specific part of the heart's electrical system was definitively involved in maintaining the circuit?
Think about the drug's mechanism. The answer is the AV node. Adenosine only causes AV block, so if the circuit stops, the AV node must have been a necessary part of that re-entry pathway.
Let's shift to structural failure. Valvular heart disease, starting with mitral stenosis, or MS, which is usually caused by chronic rheumatic heart disease.
It creates an obstruction from the left atrium to the left ventricle. The consequence is a huge back pressure. The LA dilates, pressure rises, and that transmits back into the pulmonary circulation, causing congestion and the hallmark symptom, dyspnoa.
And the clinical anchor in MS is the onset of AF.
It is. Because the LA is already under high pressure, the onset of AF is often catastrophic. The fast heart rate shortens diastole, the only time blood can get through that stenos valve, and the loss of the atrial kick causes a rapid critical surge in LA pressure, precipitating acute pulmonary edema.
Mitral regurgitation, or MR, is the opposite problem. Backflow of blood from the LV into the LA during systole.
Right, and the causes can be mild, like mitral valve prolapse, or acute disasters like endocarditis or papillary muscle rupture.
Acute MR is a hemodynamic catastrophe.
It is, but chronic MR leads to massive LV volume overload. The LV compensates by dilating, which gives you that active rocking displaced apex beat and the classic pansystolic murmur radiating to the axilla.
Management is about function. Patients need repair or replacement when symptoms worsen, or if the LV starts to fail from the chronic volume overload.
Moving to the aortic valve, aortic stenosis, or AS, is a fixed outflow obstruction. In high-income countries, it's usually calcific aortic valve disease, wear and tear.
And the pathogenesis anchor here is the LV's heroic, but ultimately self-destructive compensation.
Exactly. The LV develops massive concentric hypertrophy to generate the pressure needed to get blood out. But that huge muscle mass increases oxygen demand while simultaneously reducing the capacity for coronary blood flow. So you get angina even with normal coronary arteries.
And the prognosis anchor for AS is terrifyingly clear.
It is. Once the patient develops any of the big three symptoms, angina, syncope, or heart failure, their untreated life expectancy plummets to just 3 to 5 years, which makes treatment like AVR or TVI mandatory as soon as symptoms arise.
Aortic regurgitation, or AR, is the backflow of blood from the aorta into the LV during diastole. This is the ultimate volume overload lesion.
The LV fills from two sources at once, and patients can be asymptomatic for years because of the LV's massive compensatory dilatation, but the clinical signs are unique. You get these conspicuously pulsatile major arteries and a dramatically wide pulse pressure.
Okay, now for the great vessels. Aortic aneurysms. Abnormal dilatations, most commonly the abdominal aorta, or AAA.
And the risk factors, smoking and hypertension, are almost universally present.
Screening is crucial. In the UK, men over 65 are screened with ultrasound, and elective repair is recommended when the AAA reaches 5.5 centimeters.
Right, because at that point, the risk of fatal rupture exceeds the risk of the repair surgery.
Aortic dissection is arguably the most dramatic presentation in all of cardiology.
It is. An intimal tear allows blood to jet into the media layer, splitting the aortic wall into a true lumen and a false lumen.
And the clinical anchor is the classic description: acute, severe tearing pain.
In the chest if it's the ascending aorta, or in the back between the shoulder blades if it's descending. Collapse and shock are distressingly common.
Management is entirely about location. Type A, ascending, needs immediate emergency surgery.
Type B, descending, is managed medically. The focus is on reducing the force and velocity of blood ejection from the left ventricle to stop the tear from propagating.
So the drug target is key. Beta blockers are used to keep the main arterial pressure tightly controlled, somewhere between 60 and 75 millimero Hg.
It's a gentle, controlled lowering to reduce the shear stress on that torn aortic wall.
We also have to touch on peripheral arterial disease, or PA. It's the silent partner of CAD. It affects about 20% of older adults, but most are asymptomatic.
But its high annual mortality is almost always from MI or stroke, reflecting the systemic nature of the atherosclerosis.
Acute limb ischemia, or ALI, is a surgical emergency, and the clinical anchor is the mnemonic of the 6 Ps.
Pain, pallor, pulselessness, perishing cold, paresthesia, and paralysis. And crucially, the presence of paresthesia and paralysis means irreversible ischemia is imminent.
And it's important to distinguish between an acute embolism and a thrombosis in situ.
It is. Embolism is sudden, severe, and often from a source like AF. Thrombosis is more gradual, less acutely severe because collaterals have formed and is associated with a history of prior claudication and hard calcified arteries.
A quick note on diabetic vascular disease.
Diabetics get disease in the small calf vessels. Arterial calcification gives you spuriously high ankle pressure readings, and sensory neuropathy means severe ischemia can be completely painless, leading to tragically late presentations.
Let's review that distinction clinically. A 70-year-old presents with acute severe leg pain and pulselessness. They have a history of long-standing claudication, and you palpate hard, calcified arteries. Is this more likely an embolism or an acute thrombosis in situ?
The context here is everything. The prior claudication and the hard calcified arteries that strongly points to an acute thrombosis in situ, happening on the background of long-standing PAD.
We'll conclude our deep dive with systemic pressures in the heart's immediate environment. Hypertension is defined by a threshold, say 140/90, where cardiovascular risk starts to climb significantly.
But diagnosis is complicated by white coat hypertension. Up to 20% of patients with a high clinic BP have normal readings at home. This is why ambulatory or home BP monitoring is so important. Those readings are systematically lower and correlate far better with actual end organ damage.
And here's the core risk anchor for treatment. While the BP number is a powerful predictor, your treatment decisions must be based on the patient's absolute cardiovascular risk.
It's just a matter of therapeutic efficiency. Treating a high-risk patient might prevent one event for every 4 patients you treat. For a low-risk patient, you might have to treat 40 to prevent one event. You focus your interventions where you get the most absolute benefit.
When control fails, we talk about refractory hypertension. The most common cause is simply non-adherence.
But you always have to rule out secondary causes like renal artery stenosis or a pheochromocytoma.
A rare but devastating emergency is accelerated or malignant hypertension. This is characterized by rapidly progressive end-organ damage retinopathy, renal failure, encephalopathy.
And untreated, it's fatal within months. But the management caution anchor here is critical. Do not drop the blood pressure too fast.
I know.
Because a precipitous drop can compromise tissue perfusion in the brain and kidneys due to altered autoregulation. The goal is a controlled reduction to around 150/90 over the first 24 to 48 hours.
Okay, finally, let's talk about the heart's wrapper.
Yeah.
The pericardium. Acute pericarditis is inflammation of that sac.
And the clinical anchor is the specific quality of the chest pain. It's retrosternal, it can radiate to the shoulders, and it's classically worse with deep breathing, movement, or swallowing. Patients often feel better leaning forward.
And the classic diagnostic sign is the pericardial friction rub.
A superficial, high-pitched scratching sound. On the ECG, the hallmark is widespread ST elevation, but often without the reciprocal changes you see in an MI.
If fluid accumulates, you get a pericardial effusion. If it's large, it can cause reduced QRS voltages, and sometimes you can see electrical alternans.
Which is where the QRS complexes alternate slightly in amplitude, because the heart is literally swinging back and forth within that fluid-filled sac.
And that can lead to cardiac tamponade, acute heart failure caused by compression of the heart.
The pressure prevents adequate diastolic filling. It presents with the classic triad of hypotension, tachycardia, and a grossly elevated JVP.
And the most specific sign, which we've already discussed, is pulsus paradoxus.
Treatment is urgent aspiration pericardiocentesis under echo guidance. But we have to reiterate the critical warning from the sources.
If the tamponade is caused by cardiac rupture or an aortic dissection.
Aspiration may precipitate fatal bleeding. In those cases, immediate surgery is the only real choice.
Okay, final reflection point. A patient in the ICU has increasing shortness of breath. On their cardiac monitor, you notice the QRS complexes seem to vary slightly in height from beat to beat. What is this phenomenon called, and what does it suggest is happening inside the pericardial sac?
Think about the physics of the heart floating in a bag of fluid. The phenomenon is electrical alternans, and it strongly suggests a large pericardial effusion, potentially leading to tamponade, because the heart is swinging freely and changing its electrical axis with every single beat.
That concludes our intensive deep dive into cardiovascular essentials. We started with the single myocyte, the calcium key, and the sliding door, and we scaled all the way up to the fatal consequences of unstable plaque and the devastating, self-accelerating nature of heart failure.
And the conceptual frameworks are really what's key here. Remember the aorta's Windkessel effect, maintaining that critical diastolic perfusion. Remember the overwhelming power of Poiseuille's law, where a tiny change in radius causes a massive change in resistance. And remember that the core of treating heart failure is breaking that vicious neurohumoral cycle.
And here's a final provocative thought for you. We noted that hormone replacement therapy is associated with increased cardiovascular risk and isn't a prevention strategy. But on the other hand, patients with Marfan syndrome benefit significantly from beta blockers, or ARBs, to reduce their aortic dilatation risk. This begs a fundamental question that really defines a lot of cardiology. Why is it that these external hormonal and neurochemical signals like adrenaline, estrogen, angiotensin, why can they sometimes provide necessary structural support and other times drive pathological fibrotic destruction? It's that incredibly nuanced interplay of structure, genetics, and signaling that you're going to spend your career mastering.
So as you move forward, use this deep dive as your reference. If concepts like Mobit's the second lock, or the hemodynamics of aortic regurgitation, or the difference between a type 1 and type 2 MI felt a little less firm, just rewind and reinforce that anchor. Mastery really does come from synthesis and repetition.
We'll see you on the next Deep Dive.